So Madhav will take us through those 15-20 minutes of his presentation. Then probably we'll take some questions or any comment from you on this section.
Sure. Sir, we are good to start, sir.
Okay. Yeah, good evening, friends. Welcome to this Tuesday evening critical care sessions. We always try to bring some important topics of your interest. And today we have one more futuristic topic, the AI interpretation and its role in medical science, more so in critical care, and more so Dr. Madhav will spoke on POCUS. So Dr. Madhav is joined us as a consultant in the Department of Critical Care Medicine, Yashoda Hospitals, Hitec City. He has been a part of Medanta in the recent times and trained under Govil sir and with close associates with all these focus on AI work. That's what I could actually learn from even Dr. Shrikanth Srinivasan. So Dr. Madhav will give us an overview of presentation in 15-20 minutes to give us an insight into what is the role of AI in focus. And Dr. Shrikanth Srinivasan, who is my good friend, and I've been seeing him working with WinFocus and sonology and focus and role of sonology in critical care for the last maybe a decade and a half. So we welcome Dr. Shrikanth Srinivasan, who has been head of Manipal group of hospitals in Delhi. We welcome you, Dr. Srinivas.
Thank you, Dr. Venkat.
So over to you, Dr. Madhav, for your presentation.
Thanks for the introduction, sir. It's a pleasure having this great session. So today our topic is artificial intelligence. So what is AI? Everybody nowadays using this artificial intelligence, from small mobile devices to the TV we watch, that the AC that we interact. So everywhere the artificial intelligence is just being added as a something like futuristic and advancement in the technology and human interaction with the machine. So what is it exactly doing? Making the machine more personal, or is it helping us in any way? So in the same way, artificial intelligence also contributing something in critical care in a wonderful manner. In fact, artificial intelligence actually refers to the ability of the machine to think like human being. Earlier, the machine used to have this processing ability of the data and give us what we want based upon the absolute input. So eventually these things have evolved at a stage where they started developing models depending upon what we want exactly. So proceeding further, so artificial intelligence is actually the ability of the machine think like humans and reason and problem-solving abilities of human mind, like perception and ability to interpret, understand the deepest of the meanings in terms of language processing. The language processing is the final barrier for a machine to understand the human abilities to communicate things and think in a very complicated manner. So once the machines and machinery intelligence starts understanding the language abilities and processing of the language models, things will become much more intricate and more interesting. So here, the artificial intelligence is trying to get the data, and with the churning of the data, it is able to identify the areas where things gets analyzed appropriately depending upon what we exactly want, and communicating and interacting to the human entity in a useful and very evolving fashion. So the new paradigm is clinically having an intelligent software and augmenting the skills of physicians. In critical care, as we know, we do interact at the bedside with the patient in the form of ultrasound assessment and CT imaging, etc. So in many ways, these advanced technologies at the bedside help us in ability to solve various intricate problems, especially in diagnosing the difficult problems at the same time, and allowing us in performing at the bedside in a very safe manner and enhancing our ability to help the patient. So what is big data as a part of artificial intelligence? Big data is, huge amount of data that is coming in a very fast manner, in a real-time manner, and getting processed at the same time. So this ability of the artificial intelligence to handle huge amount of data in terms of quantitative ability, and also taking a qualitative output of that huge amount of data, and giving back to us what exactly we need, makes it an entirely different entity. Again, artificial intelligence is not a single monolithic entity, because it has a supervised learning part for it, and unsupervised learning part for it. At the same time, a machine learning algorithm that allows it evolve from the existing and upcoming data from the existing models and examples. So if we see the entire structure of artificial intelligence, it is you can see the evolution happening from the simple deep learning, and having artificial neural networking, where we see a particular set of data. The moment we try to access that data, and a similar data gets relatively highlighted in the form of artificial neural networks. And the same evolution is going into machine learning, where the ability of the machine to understand the data at the same time and evolve itself from the existing examples, how we have reacted to that particular models in terms of medical diagnostics and in many other ways. So the same model further enhanced itself to understand the perceptual abilities of human intelligence and language interpretation, and thus becoming an artificial intelligence. What is POCUS AI? Bedside ultrasound assessment, point of care assessment involving itself, in support with artificial intelligence, can make a huge amount of difference in terms of patient's care. It can analyze huge amount of data that helping us quantitatively to interpret this data, and it can enhance the qualitative outcome of the data by refining the data, and make us, especially the basic user, as on par with an experienced user within a very, very less amount of time, and help the patient in terms of therapeutic outcomes. So here we are going to just simply discuss the artificial intelligence at the POCUS, measuring in terms of the how much amount of the time it is going to save, and how it is going to assist in the integrated workflow, and easy accessibility at the bedside, and providing a very high quality feedback at the bedside. If you see the role of ultrasonography at the bedside, especially in echo, and identifying the diagnostic issues with the patients, and bedside assessment in terms of trauma, or a sudden deterioration of the patient, and especially in cardiac arrest. So all these things, they come together to give us a very decent help, and amazing help, especially in terms of crisis. So this involves acquisition of image and interpretation of these images, and again the testing various characteristics of that particular image, and based upon the machine learning algorithms, it interprets and gives us a final conclusion diagnosis within a very short period of time. So all these things help us in improve the efficacy and accelerate the patient's care. So most of the things currently available are related to auto VTI and auto IVC, intravenous volume assessment, intravenous the distensibility assessment of IVC, and auto real-time ejection fraction, and calculation of B lines in patient who is having a pneumonia, etc. These things are integrated into artificial intelligence in many upcoming ultrasonographic devices. So recent paper published also showed that 82% time saving can happen with auto VTI calculation, and giving us the cardiac output. Auto B-line is one-step process that we are going to discuss, and auto IVC, where we want to see the fluid responsiveness of the patient very, very quickly. And we are going to discuss a hypothetical case for the same. A 40-year-old man presented to the emergency with a complaint of fever and respiratory symptoms for the past 5 days. He has increased breathlessness for the past 2 days. So he's outside SARS-CoV is positive. So patient came to the emergency with a BP of 130/70, pulse rate of 140 per minute, respiratory rate of 32 per minute. So saturation is 85% on the room air, and the patient is requiring only 8 liters of oxygen to maintain his saturation more than 92% comfortably. And suddenly the patient had an event of desaturation and had to be intubated and put on mechanical ventilatory support. So the patient who was considered to be very much stable with and hardly requiring 8 liters of oxygen, why he has to deteriorate so fast? And in these conditions, if you want to do a CT to identify the cause and get a cardiologist to do an echo to identify the cause, it will take huge amount of time, probably a huge amount of resources at the same time, and many a times it is very difficult to gather them, especially if the patient is very much unstable in terms of hemodynamics and ventilatory parameters requirement. So what are the probable causes in this kind of sudden deterioration? So the one thing that comes to the mind is cardiopulmonary causes, sudden pneumothorax, but the patient wasn't spontaneously breathing, so the possibility of pneumothorax not so high. And pulmonary embolism, one possibility, and acute left ventricular failure. Yes, and this could be one possibility. Patient might have and ARDS. That is because patient has presented with a clear history of pneumonia, and that is worsening pneumonia. So what we are going to see now is how we are going to assess the same patient, and in a very short time we will come to a diagnosis. So to rule out the pulmonary thromboembolism, the femorals and supply veins, we can see the flow is very good. So the deep venous system thrombosis is ruled out, and then followed by we can see the lung for the amount of the aeration. You can see the huge amount of B lines. And the cardiac assessment automatically within no time, the VTI ability, auto VTI ability of the machine, revealing the cardiac output is 5.9 liters and the VTI is LVOT VTI at 22 centimeters. So very good cardiac output, and RARV chambers are not dilated here. So by looking at that simple image, you can rule out both LV failure at the same time and pulmonary thromboembolism at the same time. And these measurements are almost 85 to 90% professional echocardio, very, very important causes of deterioration in this particular patient. And you can see in the right lower corner, the last image, there is an air bronchogram. So probably worsening pneumonia had led to a sudden deterioration in this patient. We don't see any other possible causes. The patient now is intubated and ventilated. Now he is being shifted to the ICU. So in the ICU, at the same time, we have performed the lung sweep. Lung sweep is simple, single sweeping ability of the probe, curvilinear probe, to give the entire lung scanning, both left and right, and calculate a particular number of lung score, based upon which we can see how severe the pneumonia is and what are the parts that are aerated. So not only that, you can continue to follow the same by keeping the same data. So your colleague will come and look at the data and he can assess the patient again, and you see the improvement or deterioration in terms of the lung score and the areas that are aerated. So this is how the algorithm already exists inside the machine. So it gives all the areas left and right, 6 areas each side, anterior, lateral, and posterior lower parts. So you can the lung score as per the existing algorithm. So lung is clearly aerated 0, 1 to 2. The lung score can be categorized as 0, 1, 2, 4. So depending upon the particular score, you understand how much the lung involvement is there. So earlier we used to do the same thing, shifting the patient to the CT, and then there is a particular CT score to identify the severity of the COVID. So you don't have to shift the patient to CT room to identify the severity of the pneumonia to categorize it. No, you can do it at the bedside. Here, how the auto beeline tool works, as you sweep, it calculates the beelines as per the number of the beelines the set organism, the algorithm starts giving particular count to the image. So the moment you freeze the image, it calculates the B-lines and automatically a score is allocated. So that's how there will be a score generated, and the same score will be followed by the next person or by yourself over a period of time to see the improvement in the patient. So here the visual versus automatic scoring system is compared in a particular paper. This particular paper has showed that automatic counting is highly consistent with visual counting of lung B lines. So if you have to do it by visually counting, manually selecting area from area to area, and then calculating everything, probably you are going to spend huge amount of time at the bedside. The same in the manner of clinician performance at the lung ultrasound in predicting ARDS morphology. Lung ultrasound gives a valuable performance in distinguishing ARDS morphology. This is how we calculate the ultrasound score. You can see the score categorized as 0, 1, 2, and 3. 0 is where you see very good aeration, completely a pattern lung, and 1 is where you can start looking at some amount of B line starts appearing, whereas 2 is confluent B lines, and 3 the entire lung is now consolidated. You can see the pockets of a deaeration and pockets of hepatization of the lung clearly here. So this patient is started on appropriate antibiotics as per the COVID protocols and managed well with sedation, paralysis, with fentanyl and atracurium infusions, and provided lung protective ventilatory strategy as per ARDS guidelines. Now the lung score started coming down from 20 to the lung score is now 16. So see, this is the advantage. You have already kept the data, and the data is not comparable. Somebody, especially with critical, the next colleague comes and he takes over the things, and now he can see how the things are changing objectively. So eventually this patient has, underwent tracheostomy on day 5, then gradually weaned off from mechanical ventilation, about to be shifted to the room probably. And then suddenly this patient had sudden onset of chest pain and sudden onset of breathlessness. This patient is now having a serious pathology. So now again, the same artificial intelligence can be helpful in identifying the things. You can see the IVC is distended and not varying much. And look at the lung, it has confluent B lines, so suggestive of pulmonary edema. Also, at the same time, if you look at the auto VTI, the cardiac output has dropped significantly. Earlier, it was 5.9 liters. Now it is just 1.6 liters, and the LVOT VTI is very, very low. At the same time, you can see the LV contractility is very, very poor. So it automatically calculates the ejection fraction very closely and gives you a very, very decent number, which is very close to a professional echocardiologist. So thus, at the bedside, you have identified that this patient had an acute LV failure and probably due to myocardial ischemia. And this patient can be right away shifted to the cath lab looking at the ECG changes. So now this patient underwent an urgent, PTCA, then stabilized. After then, this patient is discharged in a stable condition on day 20. So what are the parameters what are the different tools that we used in this particular scenario? So one is auto VTI. VTI is, velocity time integer, where, LVOT diameter automatically helps in calculating the cardiac output based upon the heart rate. In this scenario, you can, take the help of ECG gated VTI variability charting also at the same time. So this automatically gives you the ability to identify the cardiac output probably in a minute or two. So if I have to see multiple patients' cardiac output in a cardiac ICU setup or in a bigger ICU setup, so I will use this tool probably in a half an hour or probably in an hour. I can assess all of my patients, most of them in terms of, cardiac functionality and their, lung status, etc., very easily. And it saves huge amount of time. A personal experience, yes, it can save huge amount of time. Once you started using it, it's very difficult to go back. So that's how the artificial intelligence really helps at the bedside, in patient's care and improving the outcomes. So here we see the LVOT get position. You can do it manually, but once you press auto VTI, the imaging system automatically selects the appropriate area, because that's the advantage of machine learning. It knows, it has seen a lot of images, it has fed with huge amount of data already, so it has an existing algorithm. It understand multiple images and the changes that are happening with the patient pathology or different environments. So it knows where to assess, what to look for and directly giving you what are the details you needed. And at the same time, it gives you the appropriateness of the image by color coding the image. If it gives you orange color, that is, the image is not good, then you have to tilt your probe and make it appropriate, so that whenever the green comes, the assessment will be done, and automatically you will be given the cardiac output and other parameters, including the VTI variability, the changes, etc. So auto IVC is a very simple method, that what we do manually, just putting at the xiphi and looking at the IVC that is entering into right atrium. But here auto IVC is just an advancement to what we do manually. So it continuously tracks the changes that are happening with the IVC and gives you a very, very close estimation of how much it is distendable or how much it is collapsible. And these parameters are very, very close to the expert calculations. Another thing is real-time ejection fraction. Real-time ejection fraction calculation that happens with artificial intelligence by simply, in a four-chamber view, by looking at end diastolic volume and end systolic volume, and capturing the cardiac ejection fraction very closely to an expert, almost plus or minus 10 points to an expert in 86% of the cases. So we cannot call an expert for daily assessment and to see daily progress of the patient who is getting better or improving or worsening. To see for an assessment, that's very difficult, and these things are dynamic. No, they are not static. You cannot take one number and say this patient is getting better. No, you have to track the changes over a period of time. So that is why the thing is, it saves a lot of amount of time. So that's how it allows repeating the assessment of the patient and lot of patients at the bedside, and gives you enough time so that you can take care of many other things. So here the artificial intelligence technology is the same. It is another thing is the trauma e-fast. Trauma e-fast, many of these newer ultrasound machines have already an existing algorithms where you just have to select particular area and just take an image and feed it to the position appropriately. So whoever comes late the image site location, he can see what they are looking at and what are the conditions when the patient has arrived. So the patient has come to an ICU and started deteriorating, shock is worsening, then you can just go through the images and see where exactly he is bleeding, where are the new pockets of collections, whether the hematoma is expanding or not. All these things can be considered by somebody who has come almost 10 hours after the patient entered into the ICU when you assess him. So hardly a 5 minutes of assessment gives a complete objective assessment of the patient compared to his presentation, and that is really, really wonderful. So in brief, when we see the POCUS, it is evolving. It is very early into its baby steps, but still the usability at the bedside and the ability to give great amount of assistance to the physician at the bedside is extraordinary. So what I believe is over a period of time, these things are going to evolve and much faster than we can imagine. And this will change the way we interact with the patients, and the way we deal with the diseases, and the way we take our decisions. So this is definitely going to enhance our abilities at the bedside and will be hugely impacting the patient outcomes. Thanks for the great opportunity, sir. Yeah, thank you.
Thank you for that excellent overview, Madhav. It was very what you say, attractively presented through a case. I understand that AI is in the world, not just in the medicine, but in many parts of our life, and more so in diagnostic and imaging. So if you look at the radiology, either MRIs or CT scans or any imaging, it is a part of it. So sonology is not an exclusion, so sonology will should be a part of it. And as you said, there remains a lot of inter observer variability in sonology. So you have a very senior consultant who is doing it, who has been doing it for a good amount of years, and a trainee is doing. So you do see some inter-observer variability. So maybe the AI equalizes it or may adds to it. But yes, I can see a mixed kind of response from all of us, how AI going to play a role. So to take it further, I will probably ask Dr. Srikanth. Dr. Srikanth, what do you think? You have seen the area of presentation from your the cardiac output, which I believe as a marker in a dynamically sick patient in an ICU is not easy. In a COPD, in a lung which is traumatized, or in a patient say, with a lot of lines and tubes, it's not an easy. But how do you believe this kind of VTI, cardiac output calculations in ICU going to be with this?
See, Venkat, see, ultrasound for the intensivists was itself a huge step. And we do understand how it has percolated and made a huge difference to the way we approach our patients. It's become an indispensable part of our day-to-day practice. And in fact, all the patients are eventually at some stage of time definitely scanned to get an idea of what exactly is going on. It's a real-time insight into what's the deranged physiology. Now, AI will add a huge plus to this entire thing. Why? Because it's sort of leveling the playing ground. Now, people who are trained in point-of-care ultrasound, they will be few, but the vast majority are already incorporating this practice into our critical care training. So the level of people who are trained will be very different from each other. Now, what AI is doing is basically it is making the whole process simple. You simply need to place a probe at a designated area. Your hand may be shaking, whatever it is. They have capacity to stabilize the image and suggest take a snapshot at the exact time where the image is appropriate, and it will automatically give you a VTI. So it is automatically doing something which is so complex, time consuming, and sometimes it's very difficult even for the experts to get a hand of it, right? Especially in a sick patients, as we know, a patient who is literally gasping for breath, is not able to lie flat, a lot of issues going on, a lot of lines, tubes all over the place. Getting an idea of what exactly is going on in the heart, how well the heart is functioning, whether we need to give more fluids, give less fluids, how the lungs are doing. These are important integral parts. And if AI gives rapid answers, even for the lay person on the bedside, all he needs to do is just apply a probe. Then that is an absolute plus to the way we're going to practice it. It's not going to replace you on the bedside. It's still going to integrate the data which you're trying to collate and give it in a much more simplified and panoramic fashion, as the way Madhav just showed, the entire lung in one single screen. I mean, so instead of seeing 1 zone, 2 zone, 3 zone, and you've forgotten what exactly happened in the first zone, you have the entire thing dynamically portrayed in front of you. So just imagine the amount of promise it shows to anybody, because now you can rest assured sitting at home that in case your junior is at that place, all he needs to place is place a probe exactly where it is with minimal amount of training, and it will give him reasonably good objective data to act upon. So this is definitely going to take the entire point of care ultrasound thing by storm, maybe in the few years. It is a learning tool. It's self-learning tool. So it sort of integrates and self-learns and evolves as the algorithms become more robust. A lot of algorithms are already in place. We know where exactly to place a probe and what to measure. This just refines the entire process, right? And the entire AI, in fact, the entire point of care ultrasound is based on pattern recognition, right? So the AI is based on pattern recognition. It recognizes specific patterns, recognizes what B lines are, what consolidation looks like, and once it goes into the entire process of AI, once it gets into the system, once it knows this is the pattern associated with a specific disease, it's going to start suggesting you things. And more often than not, that's going to be accurate. So I think I see a lot of potential. There's still a lot of long way to go, but it's definitely going to level the playing field to quite a lot of extent and make things much more simpler. But I just hope in the long run doesn't make us more dumber, because see, the more the technology, the more lack of skills or basic skills we start developing. See, since the time ultrasound came into the picture, we have so become so dependent on it that we've forgotten how to put lines blindly, almost, and we feel sort of blind when we actually do it blindly. So whether that's a good thing or bad in the long run, not very sure. But yes, to add on to the information and the accuracy of the information provided on the bedside, yes, a definite plus.
So, Madhav, I just was seeing you presenting from a GE machine, all those calculations. Is this machines are
Yes, sir.
already on board in India and available with those softwares, or that need to be customized to the machines? Madhav, can you hear me?
Sir, actually, these are the first generation AI, sir. Surprising thing is, yes, sir, yes, sir. Hello, yes, sir. So these are the first generation machines actually. So we know that the technology evolves from generation to generation, not in a linear fashion. It will be leaps and bounces. That's what
And
we have seen in terms of
this
both,
technology is available in the basic AI GE machines, as I say. The auto VTI is available in the venue and other when you go and other machines, which they automatically give you that the software is there. So you just have to place it. It takes out a trace and it will automatically tell you what it is. And it has
automatically identify the location.
Yeah, so and actually it's quite accurate also to quite a lot of extent, but one should be always taking it with a bit of some amount of riders to this, because one can't just blindly just trust technology at the same time. One should be proficient with the skills, but at the same time can use this when the time is of essence and when you need rapid answers.
So it will
So
be a learning
especially,
curve. And the other question is it only confined to GE or other machines do have the same kind of algorithms with AI?
See, as per my last information, GE definitely has it, and a lot of other machines are already incorporating the newer models which are coming into the market. They are incorporating the software, and they are making it much more simpler for people to perform whatever activities they wish to do.
We will take some questions from the
Another
audience.
say 5 or 10 years down the code, most of the machines which you'll have in the market will already have it. As he said, the generations of machines as it keeps changing. In fact, we have seen the last 1 decade itself how much development in the ultrasound machine has come within the last 1 decade, from what we had as a basic sonocyte machine to now what the current machines are. With regards to the resolution, the crispness of the image, the background noise and all, which is so rapidly cleared out of the system, a lot of advances have occurred, and now AI is being incorporated into most of the softwares.
So there are some questions Srikanth will take. So medical legal implication, who will be accountable for the information?
Again, medical legally implications. See, we ultimately all this is raw data. Okay, if somebody is giving you a VTI which is being calculated, right? And as I said, as Madhav told you, that this has a very strong correlation, but nothing is 100%. See, nothing is 100% when you do it manually also. See, you just move your hand a bit and then things can be something totally different. If you don't get a proper image, your VTI calculation can be erroneous anyhow. So you were in trouble when we are doing it by yourself also. And when the machine is assisting you, maybe it's a bit more accurate than what you can do by yourself. So there won't be a medical legal implication, as in, see, it is just a part of the puzzle. It does not give you a solution or does not give you an answer to the entire thing. It's just giving you data for you to collate and place it accordingly. Maybe a time will come when it will actually tell you what the diagnosis is also. But that is yet to come. And that is a time when we need to be a bit more cautious.
I think it holds good, like what you interpret on a CT scan, what you interpret on an MRI. It is similarly like what you interpret from an image and some calculations or information given by you. It is up to the clinicians only to actually hold responsible whether you want to use that information to treat the patient or not. The machine, the question probably is the machine cannot be blamed or AI cannot be blamed for what you interpret and what you find out from that information. I believe that's the maybe a. There is another interesting question, Dr. Srikanth, that operators should have a view for the machine to calculate. So if the operator don't know how to actually get that view, you mean IVC view or a your four-chamber view or your aortic area, the machine cannot calculate. So first point is there has to be an expert who can actually give a view. Is that right?
No, that is not, that is true to some extent, but not very true. That's exactly what I said, leveling the playing ground. So see, fine tuning, fine movements have to be done, which, I mean, the basic idea of where to place the probe, obviously everybody needs to know. But the learning curve for getting that fine tuning movements of the hand, which is there in the, with experts, the machine sort of, the algorithm of the machine somehow allows you to overcome that issue. So you may not get the most optimal view, but the machine will make adjustments in such a way, the artificial intelligence will make adjustment in such a way that it's able to give you the same result with probably a suboptimal view. So that is the big plus which we have in this case, because to become proficient in all the views, to get the exact, the classical view, the way it's described in the books, it's not possible in all our patients, especially in critically ill patients, sometimes not possible at all. So we most often than not have to make some kind of adjustments, we have to take some benefit of doubt, some chance of error is always acceptable. But what this does is that even with a suboptimal view, it sort of optimizes the image. So what it's going to do is probably going to help people who are rather not very, very proficient to get you a reasonable amount of data.
I think they got it. There is another question. Of course, the auto VT assumes a laminar flow, and you would exclude severe MR, HOCM,
Absolutely, absolutely.
and of also anterior mitral leaflet. Yep. But I agree that this reduces the inter-observer variability. That's, I think, a point or a comment made. So there are also questions. AI will always be a learning process. So it actually, it says it may have a different inputs once it is from 10 to 100 to 1000 to lakhs of the self-learning or the deep learning happens, and it will correct itself and may optimize the things. That is how it actually works. Other areas where sonology in ICU, something like optic nerve sheath diameter, there also I find a lot of observability. Madhav, any comments on optic nerve sheath diameter, neuro side, or
Sir, especially in neuro, what we have seen is the GE machine has a particular model available for it. The TCD flows and automatic tracing of the TCD flows. So it does not give you the diagnosis, but definitely the pulsatility index and the resistive index. As we calculate, we used to calculate manually, though. But once you take a good screenshot, automatically it gives you all the details: pulsatility index, resistive index, whether auto tracing, and at the same time it gives you the real-time view also, whether you can take a screenshot of it, or otherwise when you click the just pulsatile Doppler, automatically the calculations will continue to appear on the screen, just with a little bit of lag. So what that gives you is that minimizes time for assessment. You don't have to do the cumbersome job of putting a pointer at one place, selecting it, and then taking the distance and calculating it, then do it all on your own. So it fastens the entire job, and it gives you the most precious thing, that what you need in the ICU: time. Time is everything. If you are assessing 20 patients every day, all of your patients from from the cardiovascular point of view, and the lung and abdomen, etc., and how the patient is changing from day to day, though they might not be 100% accurate, it gives you the changes in terms of whether the patient is gradually getting better or deteriorating, and what are the changes that you have seen yesterday, what is happening today. So, and in a very, very short period of time. So that is another priceless, sir, priceless. Yeah.
so there are questions related to do this AI algorithms add any cost to your ultrasound machine, or it comes as a add-on, just a complementary?
Sir, actually, the machine automatically comes with an AI. It's an advanced machine. Even if you don't want the AI, that entire technology that feeds into that machine, and the resolution of the image, the refinement, all these things, without even AI also, they are wonderful. So you cannot lose them, even if that does not come with AI. And the AI, it helps to enhance the ability at a much higher level, and it just not it does not just gets you across the border, but it's by a wide margin. especially if you consider, amount of the, work and the time you put on a particular patient. It reduces the amount of the time that you spend at the bedside for coming to the same conclusion, and gives you high quality image. And it has a very decent operator consistency, sir.
Dr. Srikanth, a controversial question. Does this means that a good technical skill, like we see echocardiographers coming in doing and helping us doing an echocardiography, and sometimes they are pretty good and accurate also. So some of our teammates who are maybe a nurse practitioners or those who actually therapists or echocardiographers, sonologists, not a proper doctor, but they do help us in taking this information. But yes, you need to synthesize that information. It's just an information. You need to interpret in the clinical context and synthesize, and then you apply. But can they use this AI technology, give you information related to the condition?
See, I mean, whether they can use the technology, well, anybody who's a technician who has been trained to do echocardiography can definitely use the technology. It's not, nobody is stopping it from doing that. But the thing is that, should it be open and allowed for everybody? See, end of the day, it is the clinician on the bedside who is going to react to the values which are being generated, right? The big advantage of AI, what I see is going forward, is that it is giving the data in a much more simplified and a much more comprehensive manner. If you can just put it in those two, simplified and comprehensive. And as a clinician of the bedside, the onus is upon you whether you want to react to that data or not, whether it's going to really add some value to your clinical decision pathway or not. So who generates the image and how they do it is no longer dependent on the skill of the person. It is dependent more on the algorithm which is fed into the machine, with some specific writers, as you said, with regurgitated murmurs and all those things, where maybe there may be a source of error. I agree with that. So that's where your discretion as a clinician will come on the bedside, whether this data is relevant to this patient at this specific stage or not. So it does not replace the role of the clinician at the bedside. It just augments, allows you to get the data faster. For example, if I were just to give you a simple example, if you want to do a PLR and you have only an echo probe with you to decide what the cardiac output increment is in the form of change in VTI, how easy is it? Actually very easy to do it. Those people who actually do it realize that it is actually very difficult to get the same position, same thing, to see the VTI, the change in the VTI, and then to see whether there has actually been a change or not. It's extremely time consuming. PLR may sound to be a very easy test to do it, but actually to interpret the data, it's actually very difficult unless you show a change in the cardiac output. And if you only have an echo probe on the background to check out the cardiac outputs, it would be very difficult. Now just imagine having an auto VTI in the entire picture. You place a probe before, you do the PLR, after some time place a probe after. It is automatically giving you the change, and it automatically telling you whether the cardiac output has been augmented or not. So these are the kind of interventions which are going to be doing on the bedside, and which AI is actually going to help a lot in revolutionizing. This current day and age, it doesn't take away the fact that you should not be trained in skills how to procure an image in echo. But yes, especially in conditions like this where you are short-staffed, you don't have immediate access to the patient, you're probably at a distance, and you want to take some decisions regarding whether this patient is going to benefit or not benefit from my X and Y or Z intervention. This is a valuable plus tool. Coming to the controversial part, whether the nurses should do it or the technician should do it, anybody who has already been qualified to do echocardiography can do it. Nobody's stopping that person from doing it. So even nowadays, the technicians are the ones who do the professional cardiac echos. It's not the cardiologist who does it. So technicians who do it, but they have been trained in it. So they are only churning out data. It's not for the technician to sign on the report. It's a cardiologist to interpret that report and sign it and counsel the patient accordingly. So the onus will lie on the doctor.
So I find now it is interesting that we have so many, I think, intensive care beds with intensivists who are using echocardiography or a focus on the bedside as a routine tool, and most of us depend on it also. As you're mentioning, few of these machines, the newer generation machines do have integration of AI. Is it a time that Dr. Srikanth, Dr. Madhav, and our team, or even Dr. Govil's team put together, we have two groups. So one by the regular person with the AI based, and one other one with a qualified trained person doing it for at least a 50 case series and see how it makes a difference. I think this can be our data, our own data, rather than looking at some other data, because we have a huge volume of cases. How about it, Madhav? Create a own data of your own. Srikanth.
It will be the same patient, the same thing done by a person who is trained in it, and what data the AI is providing through its algorithm, whether they both correlate or not, right? That's
Yes.
exactly what you're saying, right? So, yeah, it's a totally doable thing, yes.
Doable, easy, straightforward. If that's suppose a trainee came who knows how to put a probe, but he's not been having that curve of learning curve of a few years. But there is another clinician who has spent 10 years of time in a qualified or trained person. So look at the both data and see what is the match. So that's a standard. This is an algorithm-based AI with a trainee who is helping the patient. So this can be a very quick and easy way to actually create a data. I think Madhav and Srikanth should churn out. We are all there to be a part of it. So I think it's an interesting and very, what you say, thought-provoking area. Not just a regular sonology, or the other people are talking about what are the other role of sonology in different parts in picking up different things. So there are a lot of discussions happening. So obviously AI will be coming in a bigger way, not just here, but in many parts, including the ventilatory graphics, the monitoring, or in imaging, as I was saying about both the MRI and CT. I thank both Dr. Madhav and Dr. Srikanth in bringing this topic, having some discussion, and I thank all the participants who are there for discussion and created some interest in this. Thank you all. I conclude the session. Thank you, Dr. Srikanth.
Thank you. Thank you, Madhav.